So one of the big reasons that immunotherapy doesn't work in HCC is because of the highly immunosuppressive nature of the tumors. What do you think the difference is with the NK cell engager? Why is that any different? Won't
Right,
the immunosuppression also affect that as well?
right. So this is a fundamental thing in hepatology. And NK cells are really an essential component of the innate immunity against cancer because T cells don't work very well in the liver, as we see. So CAR T cells are not working very well against liver cells. NK cells are practically the main defense against against liver cancer. Now, to answer your previous questions, when you talk about quantity, it's really about the quality. Because if you think about the healthy people, they don't have many more NK cells, and there are those who don't develop the cancer, they have functioning NK cells, not a lot. They have enough NK cells to prevent from the tumor. So it's really about the quality and the functionality of the NK cells rather than the quantity. So CAR NK cells are expected to be much more potent. On top of that, we all aware of the CAR T cells, which induce autoimmunity. That's what they do. They supposedly increase the function of T cells. One of the side effects of this therapy is autoimmune hepatitis because they affect the liver. The T cells affect the liver. We activate them, they affect the liver. Many of these patients receive high dose of steroids to fight this disease. So T cells are not the good soldiers in this war. NK cells target the liver. Now, as Daniel alluded to, and I also said that one of the major issues with treating patients with HCC is the fact that it doesn't come on a healthy liver. HCC in the majority of patients, not all of them, in the majority of them, develop on a background of cirrhotic liver. It's like the end stage of the disease. So the
Mm.
liver itself is non-functioning. You cannot provide a therapy that can risk the liver itself because you may cure the tumor and then the patient die from a liver failure. And these patients deteriorate like that.
Mm.
So it's very important to realize that these are very sick patients. Their liver is at the end. They are eligible for liver transplant if they didn't have the tumor, which makes them non-eligible for liver transplant.
Sure.
That's why they die. Now, if you look at the GPC3, it's an ideal target for HCC therapy because it doesn't target the healthy liver cells or those cells that don't express any signs of the tumor. That's why it's an ideal target, not only because it targets just the tumor, because it doesn't target the rest of the liver, which is very borderline. And if you touch it by any type of immune therapy, patients will die from liver failure. And that's a fundamental advantage of using the GPC3 as a binding or as uh, a targeting vehicle to any type of therapy on top of it, whether it's a bispecific or with a radiotherapy. So these
Sure.
advantages are very important because at the end of the day, we are not treating a tumor, we are treating a patient. The patient itself has a failing liver and is on the verge of dying from liver failure even before he dies from the tumor. And many of these patients, when you give them any type of immune therapy that touches on their T cells, practically change the delicate balance of their liver and they just die from liver failure, from infections that these patients are very prone to because the liver doesn't produce the proteins required to protect the immune system from infections, etc. So it's very important to realize that NK cells in that regard are ideal and GPC3 is an ideal vehicle.
Sure. So what I'm hearing is that the unique advantage of NK cells in the liver specifically is due to the unique physiology of the organ itself. And the fact that you wouldn't be able to send in, even if you could, even if T cells were permitted to function properly in the liver, you wouldn't want to use them because of the potential for collateral damage.
Absolutely. Because again, we are not treating tumors, we are treating patients that have a
Right.
tumor. And these patients are going to die from their liver failure. And
Right.
many of them die from the liver failure before they die from the tumor because they are not eligible for the liver transplant because of the tumor. Another
Well, yeah,
advantage is that we expect the NK cells to work much quicker than the T cells in liver cancer to have an early response. And another advantage, additional advantage, is the fact that this can be part of a combination therapy. So we are not giving a therapy that will prevent in the future to combine it with other drugs that, checkpoint inhibitors or any other type of drugs that can be combined. And many people today think that at the end of the day, it will need to be a combination therapy because none of the therapies is going to be ideal. But if you look at what we have today, I treat these patients every day. The majority of them don't respond. They develop severe side effects. Many of them cannot tolerate the first line or the second line because of severe side effects. We are practically treating them with drugs against the side effects. And again, on a background of a failing liver, so we are doing very bad, and that's why there is such a high death rate with
sure.
liver cancer. Yeah.
No, it's very interesting. It also owes to the advantages of using an alpha therapy for liver because of the shorter range of effect there. So it's a good approach. And yeah, no, that all makes sense. So one of the questions that I've got burning in the back of my mind is the ability. Now you mentioned that there's no issue with quantity, but do you see any kind of expansion and it's a NKp46 and CD16 engager? Is there any kind of expansion upon NK cell engager, like actual engagement? Do you see expansion of the NK cells? Is there any kind of um hope to get any more NK cells at the site?
So I think in the future this is something that can be discussed, or adding cytokines that will help to expand the NK cells. But we know even from studies, preclinical studies, this is NK cells behave differently in the liver than T cells. In T cell, it's really a dose-depending effect. I mean, you do an adaptive transfer of T cells. There are many calculations how many T cells to give. In this case, because the NK cells are exhausted or they don't function, if you can make them to function, they know what to do. They know how to kill tumors. You don't need a lot of them. We, as healthy people, we don't have a lot of NK cells, and they kill any tumor cells that wants to come into our liver or any cell that develops into a tumor. But if we can make these soldiers to start fighting the tumor, we can win the war. So the idea is that by improving the function of these malfunctions NK cells, we can improve the effect against the tumor. And as you said, Ben, if you add to that the alpha radiotherapy, which we expect to have a significant effect locally on the cells, again, with less effect on the healthy tissue around it. And
Mhm.
because it's going to be for the alpha therapy that we are going to use with astatine 211 is having a very short half-life of 7 hours. It practically prevents the collateral damage. And it's
Yeah,
very crucial to understand. It's a different type of oncology. When you treat a patient with a tumor, you usually try to target the tumor. Unfortunately, here we are targeting a tumor that sits inside a failing liver. And any collateral damage that we induce by the immune therapy, by any other type of drug, by radiation that goes to other cells, these patients live on the verge of like their cells, the cells of the so-called healthy liver. They are not healthy. They're all
sure.
cirrhotic cells. They practically don't function, and they are like having 1% functionality. If you take it down, then the patient dies. He has no liver. So
Right.
it's very different type of thinking when you think about primary liver tumor than any other tumor.
Yeah, it's a much more it has a much more integral function than like the breast tissue, right? You can
Oh,
afford some
absolutely.
collateral damage of like the breast
Yeah,
tissue or even the
yeah.
brain to some extent, but if
Yes.
1% of the liver, you lose it, and it's already they're so close to the edge that, right? And I
Yeah.
think one of the other things that I want to make sure we mention is the fact that NK cells, as opposed to T cells, have a much broader ability to recognize cancer cells. And if you're able to, through the NKp46 engagement, kind of overcome the inherent exhaustion, you can just get natural NK cell, like independent of the engager at that point. You can get natural, MIC-A recognition, or, things like that with your rejuvenated NK cells to get GPC3 negative HCC cells.
So what we expect to happen is exactly that the NK cells will regain their functionality. They can target the tumor. They will not affect the so-called healthy liver cells, which are not healthy, but will not lead to further deterioration of the liver. And again, as I said at the beginning, you have to realize when you meet these patients and they practically failed every therapy or they cannot tolerate any more therapy, there's practically nothing we can do for them. And the majority of patients today, even with the current guidelines to follow up them with ultrasound and alpha fetoprotein, most of them are being diagnosed at a very late stage. This is why they are not eligible for the curative therapies. So the majority of patients are not eligible for curative, and out of them, the majority of them don't respond to the therapies that we have. So practically, we have nothing to offer them. And that's why the barrier for success in any kind of a trial is very low. I always tell people, if you want to develop a new drug for heartburn, PPIs work in 92% of the patients. So the barrier is that you cannot be better than 92. But if the barrier is 18% of response, then if you have there is a scientific logic to this therapy. It's probably not going to affect the so-called healthy liver tissue. So it's going to be much safer. The alpha therapy is going to be much safer than the current local therapy that we use. So the success rate, we are not going to cure 100% of the patients, unfortunately, but the success rate is expected to be much more than the current 18 or 20% that we see with the current therapies. Even with the other local therapies, when you do TACE, which is the other local therapy, the problem with TACE is that many of the patients are not eligible because TACE block the blood flow to the liver. It blocks the blood flow to the tumor, but it also blocks blood flow to some of the cells around. And it's enough if it affects only 5 or 10% of them, the patient dies from liver failure.
Right.
Because of the low margin that the liver has. So the other local therapies, practically, we cannot use them in many of the patients.
So maybe it was just because I didn't do enough digging, but I feel like I didn't. This message of like the liver is it's a special case, because if you really need to watch for collateral damage, you need that like precision, surgeon's precision. We'll just use that term with these therapies. Otherwise, if you get any kind of like any kind of splash damage, you're going to lose the patient from liver failure.
Exactly.
I didn't get that from the messaging on like the website and stuff. It's a really strong story. It really justifies the use of NK
Naya
cells.
A very compelling story.
Yeah, it's
the
very
reason
strong.
I work with Naya is because they have not because Daniel's blue eyes. It's because it's a very compelling story.
But they're so beautiful, though.
I know. Naya is a very compelling story.
Yeah,
I mean, we've all been at the biotech industry and many of the products don't work, but here we see something which is new. It has a lot of potential in overcoming this very low barrier of these patients.
And I feel, I'm a big advocate of NK cells as well. And I think that I get a lot of pushback because people are just like, why would you use NK cells when T cells are stronger? They're just, they expand better and they're more cytotoxic than NK cells. What is the point? And it's like NK cells, they have very, very like relevant use cases in things just like this. It makes complete sense. You can't use T cells in the liver, and you definitely can't use T cells if you need to have very local activity, because you're going to get some surrounding burn.
Absolutely, Jeff. I think you're absolutely right. T cells are very good to treat melanoma in the skin. Excellent. They know how to target them. This is a totally different story. The liver likes NK cells. The NK cells, they like the liver. I can just give you another number that you can keep in your head. There is a subset of NK cells which is called NKT cells. They are only 1% of the cells in the blood. They are about close to 40% of the lymphocytes in the liver. They just live there.
Oh, wow.
That's their home. That's their home. That's where they live. So you have to think about it. These soldiers, they live in the liver. If they don't work, they don't work. But if
Right.
you make them to work, they will work there.
Do you think that it has to do with the fact that like everybody might when you say cell therapy for cancer, 90% of people are going to think, B cell ALL or some kind of like blood-based cancer. And it's like, well, the body isn't just the blood. Like the liver behaves very differently than the brain and the bone marrow
Absolutely.
and the lymph
Absolutely.
nodes. So
Yeah.
you have to consider the actual biology of the disease and not just the blood.
I agree. And I think that's a very important distinction that people need to realize that some organs, like the liver, are unique in that regard that they don't respond. You can think about even a simple chemotherapy. Liver cancer is one of the only cancers that practically doesn't respond to systemic chemotherapy. It just doesn't respond. You can give chemotherapy to any other kind of tumor, to lung tumor, colon cancer, etc. But the liver doesn't respond. So it's a unique organ. And as you said, every organ needs to have the right missile to target the tumor. And I think for the liver, the NK cells makes much more logic, and alpha therapy makes much more logic than the current local therapy that we are using. And I think any type of combination that will target the alpha therapy to the liver, or any type of a bispecific that can activate NK cells can do the work.
Now, are there any other organs? I'm thinking of like maybe the like gastrointestinal or colon that has similar physiology where T cells might not be the best choice, but NK cells make sense also in like the colon or things like that.
Well, this is theoretical, for the colon with different drugs that are being developed and different measures. Many of these people are eligible now for surgery. Surgery is
Okay,
much
yeah.
more, I would say that surgery is becoming much more aggressive now for patients with colon cancer, even when they have metastasis in the liver. We can take the metastasis out. We cannot do it in a patient who have a liver cancer and the
Liver
rest of the
cancer.
liver is sick because the rest of the liver is sick. It's not about taking out the tumor. You can take out the tumor. The rest of the liver is sick. The patient doesn't have the tumor and now he dies from the liver failure immediately. But in colon cancer, it's different. And that's why people need to think about liver cancer differently. We are not targeting a tumor. We are targeting a sick patient with a very sick liver. So you have to keep all these cells that are functioning 1% alive. And
I,
if you hurt even a minor amount of them, patient can die.
it's a very strong message. Very, very. The biology makes complete sense to me, at least. In the course of the conversation, you've converted me. It makes a lot of sense.
So I guess if we were to get a quick soundbite from you there in 60 seconds or so, when you're looking at NY303 and just the curative potential of it, what really stands out to you?
So I think if we are able in the next year to get the first in man and to show the effect that we can really have a positive effect on the liver cancer without affecting the without inducing liver failure. And again, if we can show the bar is really low, unfortunately, patients die from this disease all you know, and the 5 year survival is practically close to zero now. It's a miracle if somebody, survive. And because of all the current therapies that we have that don't function or patients cannot tolerate them, you also have to realize that many of the patients that we give them the first line or the second line cannot tolerate the drugs. It's nice on a piece of paper when you read it in a journal, but at the end of the day, there is a patient who cannot tolerate the side effects, and that's a major problem. And I think there is a high likelihood that this therapy is going to work to have less side effects and that patients will tolerate it. And hopefully, I don't believe that we are going to cure everyone. These are very sick patients, but I think we can definitely be above the current bar, which is very low.
Very good. Okay, and then I guess maybe a question for you here, Daniel, as well. Then, so with regards to this whole approach, and feel free to jump in as well here, Professor Ilan. What positive results, what success have you seen with this approach so far?
So, I mean, obviously, we've seen very impressive preclinical data. You know, I talked about reversing the dysfunction of NK cells. There's also making cold tumor hot and responsive potentially to combination, immunotherapy. I think in terms of our expectation for NY303 in the clinic, if we reach 30% response or better, this will be a game changer, therapy. And of course, this has been discussed. Some people said, why don't you focus only on alpha therapy and you don't need to have an immune cell engager? I think there's two complementary therapies. They're tackling the disease from different angles. And I think it's together, sequentially or in combination, that it will allow to go from the current 18 to 25% response to over 30% and eventually over 50%.
Fantastic, man.
I like it.
All right,
I like it a lot.
Jeff is a naturally skeptical person, and you've converted him in 45 minutes.
Well, I will say this. I have a natural inclination towards NK cells. I don't know what it is, but I do. So whenever I hear really compelling use cases for NK cells, I'm always just like, I'm on board. How can I help? I love it. So
Terrific.
Excellent. All right. Well, gentlemen, we appreciate your time. We'll get you to stay on once the stream ends, but thank you everyone for coming today.
Thank you
we'll see
very
next
much.
time.
Thank
awesome.
you.
Thanks so much.